Thank you. Now, Dr. Fennick, you want to join the podium for a panel discussion? I open the forum for questions now. Anybody has any questions, please come up to the mic here.
I know that we spoke about the overlooked kidneys, right? And then I was in the health field, I'm assuming that you'll be looking at the same number, and then so it's been overlooked by some, but then you're looking at it and it says that it can be used. So what ratio, what numbers are being used that they're looking at that you're seeing something different that it will be used? And that's one question. The next question I have for you is the waiting list. You're choosing we know that there are millions of persons on the list waiting, and then you choose one person. What's the criteria that you're looking at for that one person that you're choosing for the transplant? And the last question is the 80-year-old woman. She received the kidney a few months or weeks after she had a heart attack. So we are saying, okay, some person said, well, that was a kidney that somebody else could have received. So are you now, or in your field, your group, are you now taking age into consideration when it comes to transplanting?
So the questions are amazing. Thank you so much for asking them. So in regards to your first question, how many kidneys are discarded that could be used? That's a great question. Nobody knows. A lot of those kidneys that are discarded, it's because a lot of transplant centers believe they shouldn't be used or they shouldn't be used in their center. Like, for example, we've done such an amazing job here at transplanting our patients at Downstate that our blood group A list is almost non-existent. So sometimes we get blood group A kidneys that really should not be discarded, but we can't use them because we have like 3, or Susan would know, maybe 4 patients on the blood group A list right now. So sometimes there are limitations into the patients that got listed. So one thing is come and get listed at Downstate. We'll get you transplanted. Even we're running out of patients to transplant right now. So that's one of the reasons for our center to overlook it. How many of those could have been used? The question, that's where the money is. I think that, there are thousands, unfortunately, of kidneys who get discarded every year. How many of those would have worked in the right recipient? Probably the majority. That's probably the answer to your question. I believe probably the majority. This being said, not every kidney is the right kidney for every recipient, right? When you have a 22-year-old recipient, now what you want, that their life on dialysis, they're not going to have, most likely, they're not going to have a fatal event imminently. And so what you want for that patient is to try to get them that one kidney that will last them for life, the kidney that will last for 50 years. Now, when you have a 65-year-old diabetic who walks with a cane and had a heart attack in the past on your list, you want that patient off dialysis as soon as possible. That patient will do a lot better with a working kidney. And so a kidney that might not last 50 years is the right kidney for that patient. And providing we have the excellent medical care that we can provide to them at that moment. So organ utilization is a team sport that the center needs to perfect in order to be able to do that. I know that our center is doing it well, and I think that most centers across the country are working on doing it well. But there is always the fear that you were wrong. So, and that's what, when we're able to, almost like, put a magic wand on top of the kidney and go, ding, this one will work. That's when we'll have the answer to your question. In the meantime, I think that we're all doing our best. But the true answer is probably most of these kidneys that got discarded could have benefited somebody else. Your second question was about, now I blank because I answered too long the first one. Correct. Who should get the kidney when we get it offer? So the allocation system is very strict, right? It is based on blood group, And then there are points for patients who are highly sensitized, meaning that not a lot of kidneys can be allocated to them because they have antibodies and then it might not be a match. And then their wait time, how long they've been on dialysis and how long they've been listed. All that plays a role into their rank on the waiting list. So we allocate the kidneys to the patients who are the highest priority, but also that also matched this, what we're estimating as this compatibility between the longevity and the longevity of the person and the potential longevity of the kidney. So when we have a kidney that's been under a lot of stress and a lot of other centers are questioning whether the kidney will last for a long time, we often go and allocate it to an older recipient who does not need the kidney to last 50 years. So we will bypass the younger patients to get them a kidney that might last a bit longer and offer it to patients in their late 60s and 70s. But again, by priority of listing and wait time. So it is an algorithm that is strict, and patients who do get bypassed for certain kidneys only get bypassed because it is believed that they'll get a better kidney very soon that will last them longer. Third question. Age. So we do not do ageism. You are not a candidate just based on your age. Age is just a number. But the risk that you have a lot of comorbidities that make you not a candidate at 80 is higher than when you're 40. But we look at the whole picture. I think that every year we're transplanting somebody who's a little older because people are doing better, older, they're more active. And so age per se is not a contraindication. But you're right, the older a patient is, the higher the chance that an event can occur quicker to them. You're completely right. Thank you for your question. More questions?
Just to add to one thing what Dr. Roshan mentioned, the blood type is important. O is the highest number of people with O, then it is B, then is A, then AB. So AB people tend to get transplants faster because there are less of them. O, there are a lot more people in O, so there's a lot more competition.
I just want to recognize our outreach coordinators. Can you hear me well? I just want to say thank you to Vivian and Mary, who are really central to the work that we do in order to spread the word about the access of undocumented immigrants to transplantation. We haven't mentioned their names yet today, but thank you very much for all that you do.
I have a question for Dr. Roshan. So rule of third for dialysis centers is 1/3. You start dialysis, 100 patients with a dialysis center, 1/3 of the patients have some kind of a medical event that happens that gets them off dialysis, usually is a mortality. Now, we are saying EPTS score, which you mentioned about, and we also mentioned the word overlooked by other centers. So now, if you can expand a little bit on how we are able to better serve these patients by looking at these organs, what are we doing different from other centers that we're able to match these kidneys better?
Oh, I think that's a great question, Dr. Suresh. And you're part of the solution, really. I think that, what we've been able to do here at Downstate is to constantly look at breaking barriers to access. Like we meet almost every month and we ask ourselves, what are our current barriers? What can get patients to transplant? And so some of the solutions to access to transplant is to match well the patients and the organ. So we really have intense multidisciplinary evaluations of these patients to try and see how will they fare if the kidney doesn't work right away? Will their hearts do okay? What should we do with the fluid? What should we do with the medications? And by having this multidisciplinary plan for each patient at the time of listing them on the wait list, that's how we're able to, in the middle of the night with our on-call coordinators, have the discussion, hey, this kidney might not work right away, but we have a plan. We'll call the cardiologist, we'll call the pharmacist, we'll work together and we'll follow the plan and we can give them this organ at this point. Although other centers have overlooked it, we have a plan of how to deal with these patients once they get an organ that might not work right away. And so I think the answer to your question is increasing utilization implies dealing with an organ that will not work, might not work right away, and having a good plan and good medical care to brace the patient to that stressful time. And so the multidisciplinary approach and plan pre-transplant, I think, is what leads to success post-transplant. Is that what you were looking for, Dr.
Correct.
Suresh?
And the long-term outcomes for the kidneys that don't work right away and the kidneys that work right away?
And I think we're going to brace on that in another talk later. Yeah. But, essentially, it used to be thought that kidneys that don't work right away don't last as long as those who work right away. And I think we are breaking that myth over and over again. The literature is supporting it, because the reason why a lot of these kidneys didn't have the same long-term survival was twofold. Number one, the cardiac risk assessment was not taken into account. And so patients with fragile heart cannot tolerate the same level of renal dysfunction as those without cardiac dysfunction. So making sure that we choose well who we put the kidney that will not work right away is one step by which we ensure better long-term survival of these grafts. And number two, adapting the medications, again, through multidisciplinary management of these patients. A lot of the reasons why these kidneys did not work as well in the long term is that period where they don't work right away, the kidney is very reactive. It has what we call ischemia or perfusion injury. And so it increased the likelihood of rejection. So what we do is when the kidney is not working well right away, we've sort of boosted up a little bit the perioperative immunosuppression so that the kidney can be, we can decrease the inflammation in there, help it recover. It's had a tough day, that kidney, and it needs to be pampered. And so as we pamper it and let it recover, we found that although the kidney might not have worked right away, its long-term survival is equal to the kidney that works right away, because of the combo of our patient selection and our adaptation to the medical management post-op.
One touch in the chat here. How has the change in the CMS regulatory environment facilitated your use of previously discovered kidneys?
Well, it's not facilitating it, because we're not being facilitated right now by the regulatory agency. There is still a very strong look at kidney transplant programs outcome. And it should be there. We're managing limited resources, and we're using a lot of funds to do it. Transplant is expensive, and so there should be intense monitoring. But that monitoring should not be paternalistic and punitive. It should be encouraging and supportive. And we should look at the whole well-being of the benefit of the patient from the time they start dialysis. I think that when you monitor transplant centers too much, and I've shown that slide, what happens is people go, ooh, I'm just going to take the best organ and the best patient. And so then people die on dialysis, but you're not looking at it. You're just looking at that transplant center's outcome, and you think, oh, things are better. But it's just a Band-Aid that's covering the problem. And so to embrace better the idea that of holistic care of kidney disease and seeing transplant as the most beneficial renal replacement therapy is probably where we should go. Now, I don't know if this question also refers to the changes in outcomes. We just had a coffee mug rolled down here. And I don't know if we're referring to the change in the monitoring in transplant centers. So it used to be that just a 1-year graft survival outcome could put your program in trouble. Now we're moving to also look at the whole program, look at waitlist mortality, look at transplant rates, as well as outcomes, to see if a program is doing well or not. And I think that might be more encouraging for patient programs like ours, who are really focusing on getting patients off dialysis and back to a functioning, productive life. But time remains to be seen whether or not that will be easier, or it will be just an added reason to penalize transplant programs. So how they deal with those combined monitoring factor will be interesting.
Last question for me. What about the role of future program with respect to Hep B, Hep C, and HIV positive patients?
So sorry, say that.
HIV, Hep C positive patients for transplantation.
What's your
The
question?
future of the program.
Oh, the future of our program?
Correct.
I mean, our Brooklyn community has a huge referral base for patients with liver disease and with HIV. And we are doing great access for these patients. I think that moving towards the idea of being part of the Hope Centers that give access to transplantation to HIV positive patients from donors who have HIV themselves is a great way to look at the future of the program. You know, because it is one of the barriers, we are a high referral center. Our STAR clinic is also a highly busy and performing centers in terms of HIV. So I think these are probably where we already our HIV population has great access to transplantation. We're very aggressive in giving them access and multidisciplinary managing them. But to get even more organ potential, I think would be one of the great steps. Also, as the institution is buffering its GI department, it will be exciting to consider transplanting hepatitis C positive donors because with hepatitis C having treatment now, these organs can be very well utilized. You know, our program, which was just ramping up its volume, has not been doing Hep C positive organs, but you know, we're now got great protocols for hepatitis B positive organs that we're starting to utilize, and hepatitis C, I think, is the next step. So more organs means more transplant, means more access, and that's all it's all about. I think there's another question in the chat.
That's it.
That was okay.
We have another question over there.
Yes, we have a question. What changes will have happened to other transplant centers to adopt downstate approach to disfavored kidneys?
I think regulatory and monitoring, I think is just to continue working with the monitoring bodies to make sure that acceptors of overlooked kidneys are supported is the next step.
One last one over there.
One last.
Yeah.
I have a question for Ms. Alder. Thank you so much for the work that you were doing. I am assuming that your organization would have heard of Commission on Human Rights, New York City Commission on Human Rights. New York City Commission on Human Rights?
Yes.
Yeah, so I'm an associate human rights specialist, and we work with organizations. And seeing your presentation, I was really moved and concerned, because when you're looking at the areas, it is completely 100% discrimination. Because if those persons, they are good enough to give up themselves, give up their organs, and then it turns on the other hand that they need to get an organ themselves for survival and they refuse, it is just barely dollar sign. I also serve in the community as the chair at Kings County Hospital for the review board. And we have so many persons who come in from the Caribbean. They go, you spoke about Medicaid, but we have Metro Plus, and those persons, they are undocumented persons. They come in, they go to the hospital, they see a doctor, and then some of them would go back home, come back because they were scheduled for surgery. So I know persons who came back and they're undocumented and they came back and they had surgery. And I'm sure that those organizations or institutions, you know, those persons experience such, they know that those persons can, where they can go to get insurance, to get covered, and to get the right service that's needed. You know, so if you have not partnered with us yet, I'm calling on you and your organization to partner with us, because those persons need representation in the community. Again, I thank you. And before I leave, I'll make sure that you get my card and I get your card.
Sounds great. Thank you.
Thank you, everybody, for a great talk. And thank you, Dr. Rashawn, Dr. Fennick, and Mr. Adler. We're going to take a break now and reconvene at 10:30 for our next talk. Thank you.